ataxia due to cerebellar involvement can be a common issue seen in an individual with multiple sclerosis. Notable features within the gait cycle of an individual with cerebellar ataxia include decreased safety, unpredictable step lengths, jerky and hesitant movements, irregular foot placement, lack of deceleration and trunk control, and the use of their upper extremities for support. Their upper extremities may be in a high guard position during certain phases of gait to help them maintain their balance. Grossly, there is no muscle weakness. The muscles simply fire in an improper and inconsistent manner. Overall, they have a very inefficient gait cycle and utilize high amounts of energy. During initial contact, these patients tend to strike either flat-footed or with little dorsiflexion. Depending on balance during that particular step, the knee may either be flexed or extended. The base of support tends to fluctuate from scissoring to very narrow to wide. To prevent these patients from falling, wider steps may be utilized periodically through the gait cycle when their center of mass falls outside of their base of support. This is also when they tend to use their upper extremities for support on nearby objects. In loading response, they have an anterior trunk lean to shift their weight forward. Also, instead of the typical eccentric contraction of the dorsiflexors, they do not control the foot to the ground, and a slapping motion is seen. When looking at the knees during loading, they may begin to hyperextend because there is little eccentric contraction of the quads. In mid-stance, they may shift their weight backwards to help slow their body down. This may cause their toes to rise off of the ground. The knee hyperextends due to lack of a controlled eccentric contraction, and this is the point in gait where the most unsteadiness is seen. Because they only have a single base of support during mid-stance, they may utilize lateral trunk flexion and their upper extremities to help compensate for their impaired balance. For terminal stance, they demonstrate decreased hip extension, resulting in a decreased and inconsistent step length. They also have decreased knee flexion when compared to a typical gait cycle due to their inability to control their deceleration. Pre-swing and normal gait consists of hip and knee extension with plantar flexion. However, for ataxic individuals, they have decreased plantar flexion and utilize weight shifting tactics such as a lateral lean in order to transfer their weight to gain momentum. Initial swing and normal gait is where maximum hip and knee flexion occur, along with maximum plantar flexion for push-off. In the ataxic patient population, lateral trunk flexion, circumduction, or excess hip flexion is used to initiate swing secondary to poor push-off. A sufficient push-off is not utilized with these individuals, and it appears that their lower limbs are very heavy during the swing phases of gait. In mid-swing, we continue to see trunk rotation combined with either hip flexion or circumduction to help clear the toes. It is important to note that strategies used during swing range from exaggerated hip and knee flexion to limited hip and knee flexion. In some cases, these patients may appear to have a steppage gait pattern for toe clearance. Normally in terminal swing, you see the knee extend and the ankle dorsiflex as it prepares for heel strike. Instead, with ataxic gait, as the lower extremity finishes swing, there is insufficient eccentric control. Depending on the swing pattern, the knee either remains in a flexed position or slightly extends. The trunk may either flex forward due to the momentum transferring forward, or the patient may compensate by leaning backwards. Overall, safety, increased balance, and consistent strides are the most important factors that therapists should focus on.
I will try to fix you.
Along the kinetic chain, there are many areas that need to be addressed in this population. We have identified that lack of coordination, resulting in an inconsistent and decreased step length, to be the most limiting. For this particular video, we utilize NDT skills frequently so patients start to feel comfortable identifying beginnings and ends of movements. The treatment we are seeing here targets consistent and equal step lengths. This technique should also help to engage the central pattern generators that are utilized during gait. The patient stands between two cones that serve as visual cues. The patient then focuses on consistently stepping forward and backwards to the cones. While doing this, the therapist utilizes NDT techniques at the patient's hips. In the beginning, the therapist approximates the lower extremity every time it contacts the floor, especially at terminal and mid-stance. The swing phase is also guided by the therapist through a posterior tipping motion at the pelvis. Once the patient gains more control of the motion, the therapist then gradually decreases the amount of NDT used. It may be beneficial to add ankle weights or a weighted vest during this activity in the beginning to help control the deceleration phase. In this treatment, a whole task intervention is used as the patient walks while placing each foot on top of a mark on the floor. The marks serve as visual cues and are equally spaced on the floor approximately 2 to 3 inches from a center line. Again, this exercise is done to help improve coordination and encourage equal and consistent step lengths. At first, the therapist utilizes NDT techniques through the pelvis to help the patient facilitate accurate movements. Once the patient masters that, NDT can be diminished and a cognitive task can be added. As you can see in the video, an upright posture is encouraged by having the patient look up and articulate the number that the tech is holding up.